alaikum, and good evening everyone. Thank you very much for coming. I will speak in English. We have a few colleagues here who speak English. Great honor to be with all this fantastic group of colleagues coming late in the evening. And thank you, Dr. Moon, Dr. Azmi, Dr. Abdullah, for moderating this session. And this is a practical session to discuss the integrated approach of point-of-care ultrasound. Maybe some of you already practice bedside lung ultrasound, bedside cardiac ultrasound for sure, but there will be something new today, or maybe some of you, which is assessment of systemic venous congestion. So I will aim here today to discuss what I call the pyramid of point-of-care ultrasound, which integrates the three main aspects of assessment. And back to, or starting from the guidelines, the latest ESC guidelines, which recommended ultrasound to be part of the assessment of congestion. And for the first time, lung ultrasound is now part of the ESC guidelines in evaluation of congestion. And I believe the next update will also include systemic venous congestion as part of the guideline update. So we tended to think of congestion for many years as a left-sided congestion. So we had many details in evaluating left-sided congestion. We learned diastology, assessment of left-sided filling pressures, but we didn't do much in the right side. We only knew the IVC as a marker of right-sided congestion, which has many limitations. But that is something now that has changed. We have more information now about the right heart preload. And the traditional hemodynamic parameters, as we all know, includes the mean arterial pressure, systemic pulmonary vascular resistance, and the CVP. We all know the CVP, we all use the CVP. Some of us believe in CVP, some of us don't, but it remains an important hemodynamic parameter. But we tended to think of the CVP as an entirely a preload parameter of the right heart. We didn't think much of the CVP as the afterload of flow across the organs in this splanchnic bed. So thinking of the CVP as the afterload of the flow across the organs, we're talking about the liver, the spleen, the kidneys, the brains, is very important because going back to physiology, you see the equation here with constant mean systemic filling pressure or mean arterial pressure. Rising CVP will translate to reduced perfusion. And that is the new paradigm shift of understanding congestion. The higher the CVP, the higher the congestion on the right side, the worse the perfusion. And we have a lot of data which showed that excessive cumulative fluid balance will cause increased morbidity and mortality in our cardiac patients, whether they are in the ward or in the ICU. It's not only because of heart or lung congestion, but because of congestion in the liver, in the kidneys, in the brain, even in the intestine. And that's an interesting study which I found out a few years ago. It was recently published, retrospective analysis of patients who developed hyperactive delirium after cardiac surgery. Those of you who treat patients after cardiac surgery, delirium is a big challenge. And this study looked at the development of delirium after cardiac surgery and tried to look at correlation between delirium and fluid balance. And they found that 48 hours onwards after cardiac surgery, excessive cumulative fluid balance was strongly correlated to hyperactive delirium, which is very interesting. So why could that be the case? Could it be from brain congestion, from fluid overload? Could it be from liver congestion with release of chemicals in the blood? And we all learned in medical school the Frank-Starling curve. We all know the Frank-Starling curve. All the time talking about physiology, fluids, Frank-Starling curve, which is the red curve. And the Frank-Starling curve is discussing or explaining the relationship between preload and cardiac output. So the aim was always our aim to increase cardiac output by increasing preload. Give fluids to improve perfusion. But we were not told as much the other important curve, which is the venous return curve. You see the blue curve? This is the Galtonian venous return curve. And physiologically, it happens at the same time of the Frank-Starling curve. So while you are augmenting the preload to increase cardiac output, at certain point, if you look at the increment of the red curve, there will be substantial drop in the venous return. And that is the point of harm. And that is the point of causing harm by increasing preload, causing harm by giving fluids. But how do we identify the point of harm? Ultrasound could give us the answer, and that is the main part of what we are going to discuss today. That is a newly validated score, validated by a team in Montreal. We were not involved in the first validation, but we were involved in the second validation cohort. They started validating that in the cardiac surgical patients, and they developed a score which quantified systemic venous congestion, which integrated the IVC, the hepatic vein, the portal vein, and the renal vein. And then using Doppler, color Doppler, pulsed wave Doppler to quantify congestion. And then they developed a score. We will go through the protocol together, theoretically, and then we will practice that on our volunteer after the lecture. But in the validation study, they found a strong correlation between systemic venous congestion, or the VeXUS score as they called it. VeXUS is venous excess ultrasound. So higher VeXUS score translated into acute rising incidence of acute kidney injury and increased mortality. And lower VeXUS score, less incidence of acute kidney injury and better survival. And that is the summary of the protocol. How we do the protocol? We start with the IVC. The IVC is important. It remains the gateway of the protocol. You start with the inferior vena cava. You get the diameter. We're not talking about collapsibility here. We're talking only about diameter. The diameter will be the maximum diameter. So in a spontaneously breathing patient will be end expiratory, and in the mechanically ventilated patient will be end inspiratory. Get the diameter and then move to the next step. If the diameter is big, as the protocol is telling us, if it's more than 2 centimeters, then you go to the hepatic vein. How we do the hepatic vein? There are different ways. Most of you probably do the hepatic vein during echocardiographic study by the subxiphoid protocol. I suggest, and I usually do a different approach, which is the mid-axillary transhepatic approach. And I will show you on our volunteer why this is a better approach and much quicker and much easier. So we put the probe in the mid-axillary position, indicator of the probe towards the patient head, and that's how you cut through the IVC in the transhepatic approach. You will see the inferior vena cava, and also in the same view, you will see the abdominal aorta. So you have the double barrel view. And the recommendation as well is to measure the IVC in the short axis diameter, not in the long axis diameter. Because the IVC, when it's empty, it is elliptical and not cylindrical. So if you do it in the long axis, you can overestimate the diameter. So the recommendation is once you get the IVC in the long, you rotate 90 degrees. Now the indicator will be towards the ceiling in a supine patient, and then you get the short axis, and then you get the diameter. If you see asymmetry in the IVC circumference, you take the average of both the longest and the shortest diameter. And that's how the dilated IVC looks like. And also we observed that patients with high systemic venous pressures have dilated hepatic veins, even visually, before measuring the hepatic venous flow by color Doppler and pulsed wave Doppler. Before starting the hepatic vein, just briefly summarizing the different pitfalls of IVC and why IVC alone is not enough. Because IVC can be forcibly dilated for various reasons. In the absence of congestion, if you have a patient on mechanical ventilation, you're more likely to have a dilated IVC, even if they don't have systemic venous congestion. If you have pulmonary hypertension, if you have right heart failure, several pitfalls. And you can even have dilated IVC in young and healthy volunteers, especially athletics, without pathology. You can also have a collapsed IVC in a congested patient. Examples could be increased intra-abdominal pressure. It could be pregnancy. The gravid uterus can compress the IVC. So the diameter itself is important, but it's not enough. And that's why we need to do the further steps. Hepatic vein. I started in the mid-axillary approach. I go to the IVC in the short axis. Then I go back to the long axis to see the hepatic vein draining into the IVC.
The typical appearance of the hepatic vein is the wall that is anechoic, dark, not white. So the wall is anechoic. And if you're not sure about it, put color Doppler. The flow should be blue, because the flow will be moving away from the transducer. And that is typical for the hepatic venous flow. Blue, away from transducer, that is hepatic vein. Also, the shape of the hepatic vein is peculiar. It has the typical deer horn, cardinal gazelle. You have the typical tributaries. We usually scan the right hepatic vein if you go from the mid-axillary position, or the middle hepatic vein. It is very unlikely that you will scan the left hepatic vein. And then once you get color Doppler signal to confirm it's hepatic vein, put positive Doppler, and then you will start the interpretation. And we know that the right atrial pressure will translate into changes in the morphology of the hepatic venous flow. The normal hepatic venous flow should be like this. That is the tracing of what is the normal hepatic venous flow should be. You see above the baseline an A wave, which is the only point of reversal in the cardiac cycle in normal right atrial pressure. And that is the point of atrial contraction. This is the only time where the blood goes backwards. So it goes up, and that is because of atrial contraction. The rest of the cardiac cycle, whereas systole or diastole, the flow always go forward, which means from the hepatic vein to the IVC, which means below the baseline. And that is what you see here. Ignore the V wave, it is just a transitional wave that has no significance. And obviously, because you have systole, diastole, you have atrial kick, you have to have an ECG to accurately interpret the changes in the waveform. So why do we have flow in ventricular systole, and why do we have flow in ventricular diastole? During ventricular systole, the atrium relaxes, and that's why the flow moves forward. And during ventricular diastole, the tricuspid valve opens. And that's why we're all created to have low right atrial pressure in normal physiology, and the only point of high right atrial pressure is during the atrial kick. And that waveform is called the triphasic waveform. So remember the A, S, and D. And normally the S should be larger than the D in normal right atrial pressure. So that is how it looks like. Pulsed wave Doppler, you have the triphasic, A above, S and D below. Remember, you should have an ECG connected during the tracing. And then when the right atrial pressure increases, you will have reduction of the S wave. So there will be resistance of flow during ventricular systole. You will still have the flow predominantly below the baseline, systole and diastole, but S will be smaller than the D. And if the right atrial pressure keeps rising, what do you think will happen to the waveform? Reversal. Excellent. And that is exactly what happens. When the right atrial pressure becomes very high, the point of reversal happens. So during ventricular systole, the flow goes backwards. And you have now a biphasic waveform, it's not triphasic. And if I have this waveform, I don't need an ECG because it is different. You have a classic biphasic appearance of the waveform. But hepatic vein is far from perfect. It has many pitfalls. Those of you who are doing echocardiography, you know very well that tricuspid regurg will cause reversal of the hepatic venous flow if it's significant. And that can happen in the absence of congestion. So you cannot entirely assess congestion with hepatic venous flow alone if there is tricuspid regurgitation. So that is one of the most important limitations of hepatic venous flow. And of course, you always should have an ECG. Sometimes in our point of care machines, we don't have an ECG. So what is the solution? It will be in a couple of slides. Before I leave the hepatic vein, these are some of the other important pitfalls. If you have a patient with significant liver morphology, remember this is liver scanning, so severe liver cirrhosis, fatty liver, liver lymphoma, peri-arrest with very low flow state, you might have blunting of the hepatic venous waveform. So then we will not be able to comment on the hepatic venous flow. And that is the second parameter, which I call the king of venous excess ultrasound. Because, why it's king? You will see. This is the portal vein. Maybe it is new to most of you. It was new to me a few years ago. Since I learned it, I realized it's much more easier than all the other parameters. Why? Because you can see it usually at the time of hepatic venous assessment. I'm sure you have seen this picture before. You see the hepatic vein, which is anechoic, but you see other structure which has a bright wall, a bright shiny wall, and this typically is the portal vein. And to confirm that it's the portal vein, you will put color Doppler, and the signal is always red because the flow goes upward towards the transducer. And that is the flow reflecting the portal venous flow, and that is very important. Why I consider it kink? Because it is not affected by tricuspid regurgitation. It reflects the true state of venous congestion in the gut. Number two, it does not require an ECG because the normal portal venous flow, as you could see on your left hand side, is non-pulsatile. And you can even see that with color Doppler. If you put color in a normal patient with no congestion, you will see the color signal constant, not pulsatile. And if you put pulsed wave Doppler, you will see the change in pulsatility according to congestion. So the higher the pulsatility, the worse the congestion. And you can quantify the pulsatility because less than 30% pulsatility is considered normal. 30 to 50% is mild abnormality. More than 50% is severe abnormality. How do we quantify it? By the portal vein pulsatility index. You get the peak velocity of the maximum flow and the peak velocity of the minimum flow, and peak minus minimum divided by peak, and that is the portal vein pulsatility index. In most of the situations, I don't need to do the calculation because it becomes obvious. Sometimes you see the example on your right hand side, that is more than 100% pulsatility. There is even reversal of the flow under the baseline, and that indicates severe systemic venous congestion, and that is much more specific than hepatic vein. And here you have the two examples with color Doppler. On your right hand side you see the pulsatile flow even before pulsed wave Doppler, but I always do pulsed wave Doppler to confirm the degree of pulsatility. But even color Doppler can give you a clue towards the presence or absence of pulsatility. But there's nothing perfect in ultrasound. There are also limitations for the kink, the portal vein. The main limitations again are the liver pathologies. If you have significant liver pathologies, it might dampen the changes in portal venous flow. We have to be careful when we interpret the portal vein, not to mistake the portal vein for the hepatic artery, because they run close to each other. And you can see example at the base where you have the low impedance portal vein with the background of the high impedance triphasic hepatic artery. So portal vein is a very low flow, low impedance vessel, and even if it's pulsatile, it remains a low impedance pulsatility. Someone might ask me, portal vein looks very close to the hepatic vein. Why it is not affected by right atrial pressure? Why it's not affected by tricuspid regurgitation? Because although they are anatomically close, but physiologically they are very distant. There is a massive network of capillaries and liver sinusoids between the portal vein and hepatic vein. And these networks buffer any pressure transmission from the right atrium. So whatever flow you see in the portal vein, that reflects the state of the portal circulation, the portal vein circulation. Before I leave the portal vein, again, it was observed in 10% of healthy young volunteers that they might have portal vein pulsatility. And that is not fully understood. But that will be seen in the absence of all other signs of congestion. And I think it's a reminder to be humble about any parameter in ultrasound. We should never be blinded and following one single parameter in isolation. And then the final parameter, which is considered the most difficult and challenging parameter, which is the renal vein. Again, I'm still in the same position, by the way. Do you now understand why I prefer the mid-axillary? I didn't move much, I'm still there. The only thing I do is just go a bit inferior and posterior, slight rotation to be in the renal triangle, and then I have the kidney. We will talk about the type of probe needed later, but that is mainly requiring abdominal preset, whether with a cardiac probe or the abdominal probe. You get the kidney in 2D and then activate color Doppler. Usually for renal flow, we need good machines because the small handheld devices doesn't get you easily the renal flow assessment. Usually you need a higher end machine for renal vessels. because they are low flow, very low flow circulation. And once you get the flow by color Doppler, you have 3 types of renal vessels. 2 of them you should avoid, and only 1 of them you should interpret. So the vessels, the flow seen in the hilum, you should avoid, because it is likely to overestimate assessment. The flow seen close to the capsule at the edge of the kidney, you should also avoid, because it is likely to underestimate the assessment. The only vessels you should target and assess are called the interlobar vessels, which are located between the white hilum and the medulla. The white hilum, which is the medulla, and the cortex of the kidney. So the transition between the white and the black, this area is called the interlobar vessels. And once you see a flashing vessel with some optimization of color gain, the Nyquist limit, then you get the vessels, and then you get the tracing, and that is the tracing you will get. On your left-hand side, the normal tracing, because renal vessels are very small, you are more likely to get the artery and the vein together. Artery will be above the baseline, and vein will be below the baseline. We don't need to assess the artery. It is not part of the protocol. I only want to see the vein, which is below the baseline. And the portal vein behaves, the renal vein behaves almost similar to portal vein. So the normal renal venous flow should be non-pulsatile and continuous. And if I see interruption of renal venous flow, like the one in the middle, with interruption between systole and diastole, but I have flow in systole and flow in diastole, that is mild congestion. And if I don't see any flow in systole, and I see isolated flow in diastole, that is severe congestion of the kidney. And you can notice here that I don't need an ECG, because the renal artery acts as an internal ECG, which is one of the good things about kidney assessment. If you are able to get the vessels, you will not need an ECG. So continuous is normal, discontinuous with isolated S and D is mild, discontinuous with isolated D and no S is severe. Someone might ask me, where is the S wave in the severe congestion? Where has it gone? It is actually reversed. It is reversed upward, and now it is hidden under the renal artery. And that is the whole protocol. So putting all this information together, then we could quantify congestion. So if you have any combination of, or before that, if you have no abnormalities at all, this is VeXUS score 0. If you have a non-dilated IVC with no signs of, no abnormality in hepatic, portal, renal, that is VeXUS score 0. If you have any combination of normal or mildly abnormal, that is VeXUS score 1, which is mild congestion. If you have one severe abnormality only, that is VeXUS score 2. If you have 2 or more severe abnormalities, that is VeXUS score 3, and that is the maximum. And in my practice, I see a lot of patients with VeXUS score 3, whom I didn't expect to see them with VeXUS score 3. And maybe we have given fluids to patients with VeXUS score 3 before doing VeXUS, and now I realize it is difficult to manage fluid status without looking at the dark side of the venous circulation. But the whole protocol has pitfalls. Patients with long-standing pulmonary hypertension are likely to have high VeXUS score, but you shouldn't aggressively offload these patients, because the cardiac output of these patients is dependent on high preload. So it is not just the reflex of loading when you see high VeXUS score. You have to look at the context. If you have a patient known to have long-standing chronic pulmonary hypertension, you have to be gentle and make sure while you offload and assess VeXUS, you have to do the stroke volume and VTI to make sure that the stroke volume is maintained. That is different from someone post-cardiac surgery with normal RV and VeXUS score 3. These patients I aggressively offload and diurese. And VeXUS is a monitor of congestion, so you do it dynamically and you repeat it serially. So starting with the baseline VeXUS score, and then after decongestive therapies, whether in heart failure patients or after cardiac surgery, you start to repeat the VeXUS once or twice a day, and your aim is to reduce the VeXUS score. Patients with right heart failure are more likely to have a high VeXUS score, because remember, this is the RV preload. This is the true representation of right ventricular preload. So improvement of VeXUS score in these patients is indicator of improvement in right ventricular function. So you can look at VeXUS abnormality has RV dysfunction. Because if the RV is able to handle preload, VeXUS score will not increase. There will be no congestion in the venous side. And that's one of the physiological concepts of the protocol, that it can be a surrogate for right ventricular function. And I consider it part of RV assessment in my echocardiographic approach. I assess the contractility of the RV, I assess the preload by VeXUS, and I assess the afterload by the right ventricular outflow tract, VTI, and acceleration time. Another point of the whole protocol, if I see a patient with VeXUS score 3, I tell my fellows, we don't give them any fluids unless they have invasive cardiac output monitoring. Because remember the Galtonian venous return curve? Now you know that you are in the danger zone. Giving fluids to these patients will worsen perfusion at the venous beds. So VeXUS score 3 means don't give any fluids, think about decongestive therapies, and also assess cardiac output. Patients with high VeXUS score 3, are more likely to be diuretic resistant. And these are the types of patients who likely to need a combination of diuretics, not a single diuretic, because the renal congestion will cause the kidney receptors to be resistant to a single diuretic, especially furosemide. And our aim here with the protocol is the paradigm shift. Did you hear the term fluid responsiveness?
Yes. Yes.
I can hear lots of yeses in the room, which was a great concept, but I think it justified us giving lots of fluids to patients with the fixed aim of improving cardiac output. The paradigm shift is that we are moving from fluid responsiveness to fluid tolerance. Our aim is to stop giving fluids before the harm develops, even if the stroke volume will increase. And that is the target, to aim to achieve the fluid tolerance part. And that is the whole concept of right ventricular assessment and right ventricular preload. I will finish with a smaller part, then we can do the hands-on, but maybe before that I can take any questions if you have any.
I have a question for you.
Yes.
Thank you for your presentation, actually. I have two questions, one theoretical and one practical question. One theoretical question, that the big fall of IVC assessment, which is the gateway, as you said, it is mainly intra-abdominal, which is affected by the intra-abdominal pressure. And when we reproduce VeXUS score, we deeply inside the abdominal, we choose the portal vein, the renal vein, and the hepatic veins, which will be usually affected also with the pitfalls of the IVC regarding the intra-abdominal pressure. And we didn't include like the jugular venous Doppler approach, which is maybe even in the paper you showed in 2019 regarding the delirium, maybe reflecting the concept of the congestion and the afterload of the brain better than the hepatic vein and portal vein. This is the theoretical question. And the practical question regarding the assessment of these Doppler waves in these multiple veins. Do you need a certain preset different than our preset for cardiac assessment or not?
Sure. Thank you very much, Dr. Mahmoud. The first question is the abdominal pressure. So you are very unlikely to affect the interpretation of hepatic, portal, and renal veins with intra-abdominal pressure elevation unless it becomes significant elevation. And we don't see that commonly in our patients. Unless you have abdominal compartment syndrome, which is not common. How many patients with compartment syndrome that you see in your cardiac practice? Very few. Even in my cardiac ICU, I don't see a lot of these patients. But the IVC will be affected, definitely. That's why IVC alone is not enough. But even if these parameters are intra-abdominal, they are still reliable, and that's why the validation study included more than 200 patients after cardiac surgery. I didn't mention about ventilation, by the way. Half of them were mechanically ventilated, and half were spontaneously breathing. And there was an agreement across the validation protocol that it correlated well with systemic venous congestion. The jugular is very interesting. I personally think it has a great potential, but it's not validated yet. So maybe in the next few years we will have a validation study on the role of jugular venous Doppler, especially when thinking about brain flow, which is really interesting. But yeah, based on the study and even on our daily practice, I don't see any interference between the usual elevation of intra-abdominal pressures and the hepatic, portal, and renal veins. The second is the settings.
Yeah.
So the VeXUS is an abdominal scan. So the best way is, or the ideal is to have a curvilinear probe. But some of us don't have curvilinear probe. So you can use the cardiac probe, but with abdominal preset. So and most of machines have abdominal preset. But it's all about the settings. And that's what I do. I don't usually use the curvilinear. I use the cardiac probe with the abdominal preset because that optimizes the Nyquist limit, optimizes the color gain, and that's what you need. And that's what we will do together. We will try both, the cardiac with the abdominal preset and the curvilinear. Is that okay? Any question?
Thank you very much. I was much impressed by the presentation. But you see, in our practice, we don't have the facilities to repeat these parameters several times. But if we do and confirm that we have significant venous congestion, say VeXUS score 3, and we don't need one kind of catheter or something like this, and we did diuresis the patient, can we rely on the non-invasive parameters, the monitor, the pulse pressure variations, the VTI, as a serial follow-up rather than to repeat again the protocol? So because most of our ultrasound is done by either one specialized in this, or cannot come every time to make a serial follow-up. So can we depend on these parameters? The MAP, the pulse pressure variation, the VTI.
I'm trying to understand the question. So what you are saying is that your team who is trained in doing VTI and doing the serial assessment of the parameters they know.
After knowing from VeXUS that this patient is congested,
Yes.
and we diuresis him.
Yes, and then you just rely on the traditional
Yes,
parameters.
yes.
I don't think it's enough, and that's why we are here. The training is important and it's very easy to learn, and because the other parameters will not tell you about venous congestion. The LVOT VTI will tell you about cardiac output, but it will not tell you the change on the systemic venous side. So once
Even if you aggressively diuresis the patient, if his VeXUS score 3, aggressive diuresis, say that unless he is improving clinically.
yeah, we can. I mean, of
We
course,
can.
it's not a hard.
Our situation,
Yeah.
it's difficult. Yeah.
We are always guided clinically. So I'm not doing VeXUS to every single patient every time. I'm always guided by clinical picture. But if I see a patient with VeXUS score 3, I offload. I always repeat the VeXUS to make sure it might stay VeXUS score 3 because sometimes you see patients achieving negative 3-4 liters and still very congested, and only start seeing improvement when they are negative 7-8 liters.
Yes.
So I still think serial assessment is important. And if your team is already doing VTI, this is a piece of cake, a cherry on top. It will be very easy for them to learn it.
Well, sometimes you have a TE probe and the VTI is very easy.
You can do it with TOE, by the way.
It's good.
We can do VeXUS with TOE, but I'm not discussing this
So,
now.
let us see later.
Yes.
Tell us how
Yeah,
after we
absolutely.
finish. Okay,
Absolutely.
thank you very much.
Yes.
My question is there is a difference in doing VeXUS in addition to sinus rhythm?
Very good question. So sinus rhythm and AF, it will only change the A wave artery. You will not see A wave, but it will not affect portal vein. It will not affect renal vein. That's why again I call the portal vein the king. No ECG, no effect by arrhythmias, and no effect by tricuspid regression.
And even in base
Paced is very challenging for hepatic vein, and then sometimes you have tracings which are crazy complex with pacing and ectopics, but then portal vein helps. And see, I keep going back because these patients, the interpretation of the hepatic vein is very challenging, especially in the borderline zone. Biphasic, you will not miss the biphasic severe abnormality of hepatic vein, but the mild abnormality, which is S and D, smaller than D, can be extremely complex in paced patients with ectopics. Okay? Are you ready to move on to
Yep.
the next bit? So the next bit is left side. I'm not going to discuss diastology in this workshop. You're already doing lots of diastology, but I'm going to give you a hint. Transmitral flow, Doppler, you all do E over A wave, E over E prime. I love E over E prime, and I use it to guide our hemodynamic monitoring. You mentioned, sir, about the pulmonary artery catheter. Actually, although we do VeXUS all the time, we still do pulmonary artery catheter. So I don't think this is a substitution for pulmonary artery catheter in complex patients.
Not in complex, but if you have a E over E prime, then and you add a factor like 4 or something,
Yes.
you can get the wedge pressure.
Very good point. Can we go through this case together to answer your point?
Yeah.
So this patient is a young patient who was admitted to a hospital with fever, signs of low cardiac output, and these are the Doppler parameters shown. The E over E prime, by the way, is 11.8, not very high.
Yeah.
So if we follow this equation, it's the Negah formula, by the way.
Yeah.
He's an Egyptian cardiologist. He's the lead of the diastology guidelines of the American Society of Echo, and it's a fantastic formula, but it has limitations. So the E over E prime is 11.8, which is not high. So that equates to a wedge pressure of 15.
Yeah.
But looking into the intricates of the tracing, you will see a lot of evidence of very high LVEDP. Look at the deceleration time. It's very short. The deceleration time is 70 of the transmitral filling. Look at the pattern of filling of the transmitral flow. There is no A wave, and the patient is in sinus rhythm. So there is isolated E filling. So if you don't see isolated, if you don't see A filling in a sinus patient, that means very high left ventricular end diastolic pressure. Look at the continuous wave Doppler at the mitral valve. There is the diastolic mitral regurgitation. So do you see? So the equation, the formula is useful, but what is more important is looking at every single parameter. Otherwise, we will misdiagnose the patient. And this was a patient who was in pulmonary edema because of infective endocarditis of the aortic valve, and he had significant aortic regurgitation. And actually, his wedge pressure was very high, and the E over E prime was not accurate. So it's important to know the limitations of every single parameter, and that's the only message I have for you from the diastology aspect. Then the lung ultrasound. This is the third pillar of the protocol, which is the easiest. Probably some of you I have seen before and met before already doing lung ultrasound, and it is really easy to practice at the bedside. You can use the cardiac probe. You need a systematic approach for scanning the lungs. You are mainly looking at the pattern of aeration in the lungs to diagnose congestion or no congestion or loss of aeration if there is consolidation. This is the simplest systematic approach, and this is the approach we use in emergency. It's called the 3 points protocol. It's called the blue protocol because it was validated by a French anesthetist in emergency. If you are managing heart failure patient in the outpatient clinic, don't use that approach. Use the more detailed approach, which includes 2 anterior, 2 lateral, and 2 posterior zones. That is the 6 zones, because you will have more time with your patient. Lung ultrasound is very useful. It is far more superior in sensitivity and specificity than X-ray, but it is not gold standard for thoracic imaging. CT chest remains the gold standard because ultrasound is a focal scan, so it does not give you the global view, and that's why you should have the systematic approach. What do we see with lung ultrasound? When we put the probe on the chest, this is the first artifact, which is the A lines. Horizontal reverberation artifacts to the pleura at the top. This is a cardiac phased array transducer. You have the pleura at the top, and you have these reverberation artifacts coming all the way down, occurring at equal distance from each other. If you see that, that indicates no congestion. With very high precision and very high accuracy than chest X-ray, and very high accuracy than clinical symptoms. If you have congestion, you will start to see vertical artifacts. You will see the B lines. The B lines are the sonographic biomarker of congestion, the biomarker of extravascular lung water. The higher the number of the B lines, the worse the congestion. And that's how we can quantify pulmonary congestion. And that's how we can integrate lung ultrasound in assessing left-sided filling pressures. And that's what the ESC guidelines now recommend. But B lines does not only occur in heart failure. It can also happen in non-cardiogenic pulmonary edema. Anything that raises lung water will cause B lines, whether it's inflammation, infection, or congestion. But we can differentiate between both, and I will show you very shortly. But before that, we will go through the cascade of aeration, the 4 shades of gray. You have at the top the A lines, normal aeration. Then in the middle, you have the B lines, which can be separated B lines, early congestion, which is interstitial edema, where the fluid in the interstitium of the lung. These patients are usually hypoxic on exercise, not at rest, not in pulmonary edema, not requiring oxygen at rest. But then the third pattern from the top is the alveolar edema, where the fluid floods the alveoli, and this is the patient with frank pulmonary edema. We call him in Egypt بيبقلب. This is the patient اللي مبقلب في emergency. This is the patient that you need to put a CPAP, you need to give morphine, you need to act quickly before they get intubated. And how do you know that the patient is in frank pulmonary edema? Is seeing the B lines filling the whole screen, and that is alveolar edema. But both patterns of B lines represent an intermediate loss of aeration. Because if I have total loss of aeration, I will see the lung appearing as a tissue. And that is the only time the lung appears as an anatomical structure. All the other findings are artifacts. A lines are artifacts. B lines are artifacts. But the consolidation, or the C profile, is a true pathological structure. And looking at the ABC pattern, A lines, B lines consolidation, you can use lung ultrasound to monitor aeration, worsening or progression of aeration. And this is a consensus document, open access, published by the ESCVI for using lung ultrasound in acute and chronic heart failure. There are lots of tables, algorithms to integrate lung ultrasound with echocardiography in managing patients with heart failure. Now the question, how can I differentiate between heart failure and infection if I see B lines? First, clinical approach, clinical context. Second, with ultrasound, you can have clues. The pleura in heart failure is usually thin and healthy. If you see the pleura thickened and irregular, that is an indicator of inflammation. The next point is the pattern of B lines. The normal pattern of B lines in congestion is symmetrical, bilateral, more at the base. If you have pneumonia or ARDS, the B line pattern is patchy. Like what you see on the CT scan, the ground glass. And actually, we actually mentioned in the study that the B lines correlate well with the ground glass opacification seen in COVID-19 patients. So A line, the pleura, thin in heart failure, thickened and irregular in pneumonia. The B line pattern, symmetrical, bilateral in heart failure, patchy with areas of A lines in between in patients with pneumonia. And finally, in patients with ARDS, you're more likely to see consolidations, especially big consolidation at the bases. But of course, you can have a combination of both, heart failure and infection together. And finally, the last word is B lines are too sensitive to the point that it can tell you about congestion very early in the congestion cascade. And this example here, this was a case published in one of the journals, which discussed a gentleman presented to the emergency department with atypical symptoms. Atypical mild chest pain, no previous comorbidities, he was middle-aged, non-smoker, a bit elevated body mass index, and he presented with mild chest pain, with no specific ECG abnormalities. And the first troponin was negative. The emergency physician back in this hospital luckily knew how to do lung ultrasound. He was doing echo, and then looked at the lung, he saw B lines everywhere. And that was shocking. Why would there be lines everywhere in a young patient with normal ECG? So looked at the echo, there were wall motion abnormalities in the anterior LAD territory. Patient taken to the cath lab, there was a critical left main occlusion. And the LVEDP recorded in the patient in the cath lab was 3536. So the message, when they published this case, the message was lung ultrasound can save lives by giving early indication or indicator of very high LVEDP in the absence of typical ECG or typical history or typical troponin rise. And also now lung ultrasound is part of the stress echo protocols. You can detect the appearance of B lines very early when you exercise the patients, whether pharmacologically or with physical exercise. And you see the B lines before patient becomes breathless, before patient becomes hypoxic, and before any ECG changes. And finally, we always recommend integrating lung with cardiac ultrasound. We described here 4 types of shock, where you had both cardiac and lung ultrasound. At the top, you have septic shock with vegetations in the aortic valve, vasodilatation, vasoplegia with hyperdynamic LV, preserved LV in diastolic volume, and a small IVC. Panel B was a patient with cardiogenic shock who had severely impaired left ventricular function, had a dilated IVC and bilateral coalescent B lines. Panel C was a patient with obstructive shock who had dilated RV with flattened interventricular septum. Patient had a clot in the common femoral vein, so we can even do ultrasound further to the deep veins to look for the reason for pulmonary embolism. And this was a patient with acute pulmonary embolism with bilateral A lines, by the way, because he was not congested. And the final patient in panel D was a patient with hypovolemic shock, small ventricles, hypercontractile, small IVC, and bilateral A lines. And that is an algorithm that provides a stepwise approach to troubleshoot hypotension and shock, integrating lung, VeXUS, echo, and also strain imaging. Although we have very limited data on strain imaging and it's not yet available at the point of care, but now there are vendors trying to bring strain echo into the point of care. I think maybe, hopefully, in the next years, we will see strain imaging coming to the point of care because it's more reliable in evaluating contractility. And that is the pyramid of point of care ultrasound: cardiac, lung, and VeXUS. And I think it's time to do the practice. But first, I'll take some questions if you have any before we do the hands-on.
Tell us how to use CA block for.
We can. Absolutely. We can do VeXUS by
I
transesophageal.
don't have any material.
Yeah, we have material. Yes, absolutely, we have.
Can you see now?
I don't have in my lecture, but there is actually a textbook written on transesophageal whole body ultrasound, and I highly recommend. It is written by the VeXUS legend André Denon in Montreal, and it's a great book. Transesophageal whole body ultrasound.
دكتور ازاي بنفرق بين في lungs اذا تعتبر normal بنشوفها في
Very good question. I didn't discuss pneumothorax because this is a congestion session. Absolutely good question. Pneumothorax, you will have first no pleural sliding. I didn't talk about sliding, but lung ultrasound includes assessment of the pleural sliding. Normally, the pleura should be seen shimmering. You see the movement of the visceral and parietal pleura. If you see the sliding, you 100% exclude pneumothorax. If you don't see sliding, there may be pneumothorax, maybe not pneumothorax. Because to diagnose pneumothorax, you should have several parameters. The most important is the lung point, which is the area of the sliding meeting of area with no sliding. And that is the edge of the lung and the edge of the pneumothorax. So,
How practically to see the lung point from?
very practically.
And
How do it? How we do it?
Yes, by the fore anterior, lateral anterior.
So no. So the systematic approach I showed is a congestion approach.
Okay.
For pneumothorax, you should scan every intercostal space. And you should start from laterally to medially. Because if the pneumothorax is small, the lung point will be very lateral. Right? Because this is the meeting point between sliding and no sliding. And then you move medially. But you have to do every single intercostal space. Of course, you start with the side where you suspect pneumothorax, clinically.
So you start every space anterior and posterior.
Anterior, no, because pneumothorax, it goes up against gravity. So you always scan up. In congestion, you always start at the base and go up. Pneumothorax, you start mainly anterior, because this is where you see the air. You see the evidence of the air. Did I answer the question?
Yes.
Very good. Any other question before we do the hands-on?
Captain, I want to make use of your experience in your center. How can ultrasound help us to confirm post-cardiac surgery vasoplegia?
Great question, because we see it a lot. So, especially after a long bypass, you see patients coming with vasoplegia, not sepsis, just inflammation.
very high vasopressor requirement, low systemic vascular resistance. So the evidence, vasoplegia will interpret with hyperdynamic LV. And what can differentiate vasoplegia from hypovolemia is the end diastolic volume of the left ventricle. If you have a hypovolemic patient, the end diastolic volume will be small, so the heart will be empty. But if you have vasoplegia, you will have preserved end diastolic volume, more likely with hypercontractile cavity. But we see a lot of patients with vasoplegia developing right heart failure, which is a tricky combination after cardiac surgery. You have right heart failure, which impairs the filling of the LV. So you end up having a very contractile LV from vasoplegia, and underfilled LV from right heart failure. And even it can get worse, and you get obstruction on the left side, mid-cavity obstruction by the hypercontractility. And that becomes really tricky, because if you give more inotropes to help the right ventricle, that will worsen the obstruction on the left side. If you stop the inotropes to help the left heart, the right heart will get worse. So that can be very challenging, and here we cannot manage them without pulmonary artery catheter.
It's very challenging because a lot of patients with right heart failure, I think, more common than we can expect in these patients. But also, you are dealing with cardiac surgery, often CABG for ischemic patients who already dilated the ventricle, already impaired the contractility. So we cannot rely more on the hyperdynamicity of the LV because we have a pre-existing pathology before. So it's very challenging.
It is very challenging, absolutely.
I think this particularly when the patient has right coronary ventricular branch is affected and long bypass and more IV fluids post-operatively because very sensitive volume within that.
Exactly.
Or maybe after load dependent from post-capillary hypertension, which is going badly to
Exactly, and that's why I think protecting the RV around cardiac surgery can avoid all these situations, because the RV failure will make things much worse.